So good morning, everyone, and welcome to this week's Fireside Chat. I hope everyone is having a great week so far. And I'm Lisa Stearns. I'm here with Tim Cross, our Senior Vice President. We do have a special guest today. Dr. Lisa Piercy, Tennessee's Commissioner of Health, is here with us and will be sharing her firsthand knowledge of how this pandemic is affecting our state. First of all, a few housekeeping items. Always keep your audio muted so everyone can enjoy the conversation. Use the chat function on Zoom if you'd like to ask a question of either Dr. Cross or Dr. Piercy. You can use the public chat or you can send those questions to me privately. As always, this chat will be recorded and will be posted to the coronavirus website, which I hope everyone has had a chance to visit. At this point, it's chock full of wonderful information. So, Tim, let's jump right in. This week marked the beginning of phase 1 of our re-entry plans. How do you feel things are going?
Well, thanks, and good morning, everyone. And Lisa, yes, as you mentioned, for those on campus, this is really the first week of phase 1. For those across the state, some of you started phasing back last week, so maybe even a little further into our re-entry process. But I have to say, really by and large, feel really good about the progress that we're making. And I'll share just a couple examples of why I say that. First of all, I've been seeing firsthand the detailed health and safety plans that we're asking our research faculty to establish, so that when they do return to their laboratories and when their co-workers, postdocs, research associates return to the laboratories, we know that that's being done under safe conditions, making great progress with that, and that's really good. I've seen a number of exceptions reports on campus, again, for those who have to occasionally or periodically come by and pick up materials or drop off mail or retrieve supplies. That has gone well also. The College of Veterinary Medicine doing a superb job getting ready to welcome a new class and getting ready to engage their senior class in more experiential and hands-on learning that creates special challenges for everyone in the College of Veterinary Medicine. They've scaled up just a little bit the care that they're offering through their clinics. And again, I've seen very positive progress in that regard. And I think, you know, the really positive indicator to me is that most of us are still working remotely. And that is what we had hoped for with phase 1. Those who really need to have been able to return to the workplace. But across the board, we're not simply opening the doors and saying it's business as usual. We're moving into this new normal phase slowly and carefully. And the real reason of that, for that, of course, is health and safety. And I'm once again pleased to say we have no positive cases of COVID-19 within the Institute of Agriculture employees. So we're keeping that track record going. Every week I say it out loud and worried that I'm going to jinx us. But so far, thanks to you and what you're doing, we have been able to maintain that. Now, let me just wrap up sort of phase 1 remarks with this, and that is everyone needs to be reminded that our new normal, starting with phase 1, is that when you're at the workplace, you're wearing a mask and you're washing your hands regularly, you're following CDC guidance, and you're completing the checklist, answering a number of questions before you report to work at the workplace. So you say, well, I'm not wearing a mask right now. Why are you telling us to? Obviously, within your own office, within a private area, if you will, that's certainly not necessarily, and then unless you have guests coming to join you. But really, we want to emphasize the need to wear masks anytime you're out and about. And so we'll probably reemphasize that again during the course of this discussion. Following that practice and all CDC guidance, I think, just sets us up for continued success.
Great, and great advice. So many entities, including UT, planning re-entry, are looking to the number of state cases as a barometer of whether or not to reopen. So can you share some thoughts on this?
Yeah, and this will get us right into really our focus here this morning too. So as an agricultural economist, I don't claim to be an epidemiologist, so I'm not going to go too deep into data and all the various statistics and measurements that we can look at and consider as we manage through this pandemic. But I think it is really helpful to have an expert who can talk just a little bit about the status of our state and how we're doing from border to border with regard to the pandemic. Obviously, without getting into details on every single location, but we've been really fortunate to have someone at the helm that's experienced, that's capable and professional, and that is Commissioner Lisa Piercy. She's been serving as Commissioner of Health ever since Governor Lee was appointed, and she's got experience in the medical profession. She's an MD herself. She was Executive Vice President out at West Tennessee Healthcare, and those of you out in the western part of the state will appreciate that she's a West Tennessee native, so she's familiar with that part of the state as well. I happen to know that she has a heart for children, for youth, and rural communities as well. So I think makes logical connections with our Institute of Agriculture and our presence across the state. And I also want to note she serves on our Lone Oaks Farm Advisory Council. So she's no stranger to our extension and 4-H programs in particular. So with all that, you know, I sometimes refer to her as Commissioner Piercy. I sometimes call her Dr. Piercy, but I'm really privileged to be able to also say Lisa because, again, she is a friend, she's a supporter, and we're just so happy to have her join us here this morning. So, Commissioner, we turn it over to you.
Thank you, Dr. Cross, and it's good to see you and Keith and all my other friends that are on the screen and some that I know are joining that are not on the screen. So, I just wanted to start off by giving a bit of an overview of where we are, but I really would like to reserve the bulk of my portion for any questions that you may have, because I know that what I'm talking about is just what I'm thinking about, and I want to make sure that I'm addressing whatever you want to hear about. So we are rapidly reopening, and part of the philosophy behind that is economic health and prosperity is part of physical health. And that's not to say that it's more important or it is even as important, but it is an important component of that. And so as we've been watching our numbers go down over the last several weeks, we have moved fairly aggressively, not as aggressively as some states, but quite a bit faster than other states in our reopening phase. And I realize I just said something that I used a term that I don't want to use. It's habit, and I hope you don't use. And I was talking about numbers and case count. That's what I said, because that's sort of the lay vernacular. But I really encourage you to look at rates and trajectories. I know I don't have to tell anybody on this call that how to define a trend or how to look at data over time. That's something that we deal with pretty commonly amongst the lay public, but we're looking at downward trajectories. And you also have to take into consideration that the more you test, the more you're going to find. And so we have done a heck of a job in testing in Tennessee. You probably saw, it came out on NPR late last week, that a Harvard study put us as one of the only one of the 7 states in America that are doing enough testing. And of the 7 that were named, we were the most populated state. And so we're really making good strides in testing. It's getting national attention, which is both good and bad. I did interviews earlier this week with New York Times, Washington Post, and NBC News on our testing efforts, which is a real boost, but it also means that a lot of people are watching, and we have to continue doing well. So related to rates, we want to see an overall trajectory, downward trajectory of our positivity rates. Ours right now, I haven't looked at the numbers this morning, but it's plus or minus 6%, maybe a little bit less than that, of all tests are being come back as positive. Why is that important? You want to be able to test enough to where most of the tests you are getting are negative. That means your sample size is big enough. That is the same, and most of you probably haven't heard this, but it's a common, actually brace yourselves because this may shock you, but it's a very common practice in medicine that you want to have lots of negatives. You want to be conservative because the ramifications of missing a positive can be really bad. For example, the thing that might surprise you is that out of every 10 appendectomies that you do, 9, you want to find 9 of them cold. You want to catch that one hot appendix way more than you want. You want to be able to do so many appendectomies that you catch 1 out of 10. Because if you are only operating on people that you know have appendicitis and you know are going to have a hot appendix when you get in there, then you're not doing it enough. And we have the same approach to testing, because if you're getting positivity rates of 10, 15, or heaven forbid, like some of our colleagues' states that are pretty close by, Georgia, when your positivity rates are 20 and 23%, it means you're not doing enough testing. And so our positivity rates are hovering around 6%. That's a lot lower than it was several weeks ago, and that continued downward trajectory is why we're comfortable in starting to phase some of our reopening. A little preview, there'll probably be an announcement later today. It's possible that it could get bumped until Monday, but we're looking to make some more reopening announcements very, very soon, and have been talking about that just this morning. So what does that mean for kind of going back, whether at school or work or just in the community? We're going to have more cases. I mean, that's not a secret. It's not something that we're holding our breath thinking we're not going to have more cases. I'll point you back to a couple of points. First, nobody ever expected this to go away. This is not about disease eradication or elimination of cases, or frankly, even minimization of cases. You have to remember what we talked about what we were going for in flattening the curve to begin with. And when we talk about flattening the curve, it was never about making sure that the case count got to 0 or in the single digits or whatever. It was about preserving health system capacity. And it didn't take long at all, maybe a week or two, really after all of the ventilator talk was finished in late March or early April, people stopped talking about health system capacity and they started talking about numbers and cases. And we've really lost sight of what the goal here is. And the goal here is to keep the disease burden, I was about to say at bay, but we may or may not keep it at bay as much as we're going to keep it spread out so our health system capacity can keep up. We have not had anywhere close to an issue with that, although I will tell you in the last week, maybe even 2 weeks, since we started allowing for elective surgeries in our hospitals, our hospital capacity has gone down some, and that's in the face of a reduction in disease burden. So the things that worry me personally and my colleagues are this perfect storm of elevation of elective hospital cases, which, oh, by the way, I don't know if you've seen the headline in the last 24 or 48 hours, rates of cancer diagnosis have really, really gone down over the last 8 weeks. That does not mean people are getting cancer less. It means people are presenting for evaluation and treatment less, which is super concerning. We've seen the same trends with heart attacks and strokes. And there might be a little bit of reduction in heart attacks and strokes because people aren't as active and they aren't doing quite as many things as they used to be doing. But really, the incidence of that is not gone down in the population, and certainly cancer hasn't either in 8 weeks. So we think that is a reflection of people not presenting for care in a timely manner, and that's concerning. So when that population gets back up to speed, when elective surgeries get back up to full capacity, that's going to strain our healthcare system. And then any healthcare hospital administrator will tell you that a bad flu season by itself, nothing else, can really be scary and can really cause you to go into some emergency measures. And so the perfect storm would be, we have increased rates in the face of already strained hospital capacity and a high influenza burden. And so all of those things are things that we're watching. People ask me a lot. In fact, the governor just asked me yesterday about this common, I don't know if it's a myth, but at least it's a commonly held belief that the heat and humidity is going to tamp down on this virus. There's actually no evidence for that. People want that to be true, and we hope that's true. And I can't say that it's not true. We can't rule that out. But, you know, we've been studying coronaviruses, that family, for a long time, and there's really not any indication that it will be negatively, or I guess you could say positively, impacted by heat and humidity. What is affected by heat and humidity is that people are in the house less and they're congregated less. And, you know, people are indoors and around more people in the wintertime just because of the weather itself. And so whether it's the actual heat and humidity or just the congregation of folks in confined settings, we do expect to have a bigger surge in the fall and winter, which for all the aforementioned reasons of influenza and hospital capacity, et cetera, make us pretty concerned about that. So what are we doing now? Let me, a couple of comments about that, and then happy to take questions. We're having a really targeted approach of testing vulnerable populations. You've probably heard us talk in the media about long-term care facilities, which includes nursing homes, but it's not limited to nursing homes, as well as the incarcerated population. We have just finished widespread mass testing of all prison inmates and prison staff statewide. We're the first state in the nation to do that. And so those results, the final numbers should be in today on the last one that we did earlier this week. And so we've had many, many cases. I think just a few over 2,500 of our 16,000 cases are in the correctional population. And so that makes our numbers look higher. But whether it's nursing homes or prisons or other vulnerable populations, contained populations, juvenile detention, right now, today, as we speak, we're testing housing authorities in the major metro areas. When we look for cases, we're going to find cases. That doesn't surprise or shock us, but you should know that context before you interpret the numbers. Finally, we're expanding our testing efforts for more corporate and employer populations, and that does include THEC in our university system. So we've been in frequent discussions. In fact, I think there's a meeting later today with Mike Krause, and Randy Boyd and I have spoken frequently about this, about how do we keep our campuses safe, and particularly amongst the residential student population, of which there's about 26,000 students statewide in residential housing. And so we're actively developing a plan for testing of students and faculty, particularly those that will be potentially be in person, as well as other employers. You know, we're starting to bring, I should say, state employees back to the office at the end of the month and over throughout the month of June and into July, and how we can offer testing for that population, as well as other corporate populations. We're working with Electrolux and Nissan and Volkswagen and other large employers. Final comment, just to debunk some myths. Testing is good for that day, and that is the recognized limitation. People oftentimes say, well, why would you find value in mass testing these populations when you essentially are only getting a status for that day? That's entirely true. The only way to respond to that is it's the only tool that we have. And if we can test our population somewhat in a point prevalence study and find out who's positive today, we can affect people that might be, that might spread that infection today. We can affect that today. That will beg the question for retesting, which we will have to do, but we can only use the tools that we have in our tool belt, and that's what we have today is PCR testing. I can get into antibody testing if you guys want to talk about that. The short version is it really hasn't panned out the way we thought or would have liked. Presence of antibodies doesn't necessarily confer immunity, so it's more valuable in public health surveillance and in seroprevalence statewide, but it's not necessarily too helpful on the individual level. So I'll stop there and happy to take your questions.
So, Dr.
I'm sorry, go ahead, Lisa.
Just as a follow-up, someone asked that if you're asymptomatic, is that only good for one day as well, if you were to take the test?
Yeah, so the test results really are only good for that day, no matter who you are or what kind of symptoms you have. And that has less to do with your current symptoms and more to do with just the spread of infectious disease. So generally, we know that your test won't come positive until at least about 2 days after you're exposed, and it has the highest likelihood of coming positive about 5 to 6 days after you're exposed. Now, for those that are asymptomatic, they can be at the height of their infection and transmitting it like crazy, but still be completely asymptomatic. And so that's why it's really important, even if you're well, if you're returning to a setting where you could pose a risk to others, to know your testing status. One other point about asymptomatic spread that I hear bad information perpetuated pretty commonly. Most of the talk about being asymptomatic that we've had has been in regards to the prison population. And in retrospect, maybe I shouldn't have been so verbal about it, but it was so scientifically fascinating to me that we did talk about it publicly. It wasn't wrong. It just created some confusion because particularly in the inmate population, 98% of those 2,500 positives were completely asymptomatic. They were well, which caused people to think that that could be extrapolated to the general population, and it can't. We think maybe at most 25% of people who test positive are asymptomatic. Most people are sick when they test positive, but there is some rate of asymptomatic spread in the general population. But in congregate care settings, like in prison populations and in nursing home populations, the rate of asymptomatic carriage is much, much higher. That is what is so physiologically perplexing, because that really doesn't make any sense as in that congregate care setting as it would in the general population. So the bottom line is most people are symptomatic, but even if you are feeling well, you still very well could have it and could be transmitting it.
So, Dr. Piercy, in thinking, well, as you know, we have a number of extension offices across the state, in fact, in every county. So this person is asking about offices and office buildings, and they're asking that if these offices can't meet CDC guidance and regulations due to the age of the building and where it's located, if it's poor ventilation, sanitary conditions, inconsistent temperatures, et cetera, is it a possibility that employees could continue to work from home? They're asking about that. Is that a good idea, in your opinion? Is the building somewhat of a risk?
Yeah, I mean, that's a good question. And some of you know, my husband is in industrial safety and hygiene. And so we talk a lot, well, quite frankly, not that much. It's not that exciting. But we do talk sometimes about, physical infrastructure and its ability to influence or promote disease spread just based on the physical plant. And quite frankly, the answer is a little bit, but not very much. You have to remember that the overwhelming vast majority of transmission is person to person. And there's a lot of misunderstanding out there about droplet versus airborne. This does not hang in the air by and large like measles does. For example, if somebody checked into a hotel an hour before you did and they had measles, you might be at risk just by going and checking in that same space. This is different. There are ways that the disease can become aerosolized. Probably the most notable would be through dentistry, when they put all the little high pressure spray, and that can aerosolize it. And respiratory procedures like bronchoscopy can, but otherwise it really is mostly just larger droplets. And some of you know that I sometimes make snarky comments. And so my snarky comment on this is, don't lick the doorknobs, and, don't put things in the office in your mouth. And that's probably the best way to protect yourself. I'm being a little facetious to prove a point, but sanitary conditions, ventilation, if it's good enough to house, it's probably fine. Really, the main thing is human-to-human transmission, and making sure good hand hygiene, wearing your mask, staying distance. That's going to protect you way more than worrying about an older building.
So, Commissioner, we know. Go ahead.
Excuse me. I was gonna say, I see a question about false negatives in the chat, and I'm happy to take it. And then I've got to do a 10:30 call, so I'm going to have to jump off. But there's a question about false negative rates, and actually been dealing with this issue just this morning. There are, first of all, you guys know this, but just to level set, because it's come to my attention that apparently the general public seems to think that every medical test is 100% accurate all the time, and that's not true. Just to give you a point or a frame of reference, the strep screen that you get is about 22%, has about a 22% false negative rate. And so if you've ever been at the doctor or had your kid at the doctor, and you know what strep looks like and smells like and feels like, but you test negative, that's why they'll treat you anyway, because that test is not 100% accurate. No different with this test. When you use the standard traditional, what we call PCR test, that has about a 4 or 4.5 hour turnaround time once it's in the lab, that has a 92 to 93% accuracy because it has a pretty high sensitivity rate. When you start using some of these rapid tests, and everybody wants the rapid test because nobody likes to wait for anything anymore, there are these 15-minute tests, Abbott ID Now, and then one came out maybe Friday or Monday of this past week called Quidel. The president was touting it just as he did with the Abbott ID Now. There is a huge, huge trade-off between rapid test and false negatives. So the false negatives for the Abbott ID test may be as high as 15 to 20%, and the Quidel test may be another 10% on top of that. And so when you talk about really making decisions based on test results, you need to look at your false negative rates. The false negative rates on the traditional swabs are still really low, but the rapid test, be forewarned, because they really have higher rates than are generally acceptable.
Well,
let me jump in and just express my appreciation to Commissioner Piercy for giving up the time today to visit with our organization. Really appreciate it. I know your schedule has been incredible and challenging for the past probably 10 weeks now. Thanks so much for sharing with us, Lisa. Really appreciate it.
Good to see you, Tim. Thanks, everybody. Have a good weekend.
You too.
You too. So, Tim, you're back on the hot seat here.
Nobody to pass the hard questions to now.
So actually, it would have been helpful to get a little bit of her take on this, but I think you also can address this. This person is acknowledging what Dr. Piercy talked about, and that was the fact that we are aggressively testing people here in the state of Tennessee. And the person asked, the national guidelines for reopening are going on percentages of new cases per number of tests. So as we look at Tennessee's numbers in most counties outside of Shelby and Davidson, percentage of new cases is steadily decreasing. However, with that many tests going on, the number of new cases continue to rise in some counties. May we go by the percentage rather than the number of new cases in our counties when we're making decisions about reopening these extension offices in particular?
Yeah, great. And I think we heard actually Commissioner Piercy speak to that, and she mentioned how important it was to look at rate as opposed to only focusing on number of cases. So I think we need to, obviously look at both. If you've got a community with a small population, that a small number of cases actually has a potential large impact, that could be important. But likewise, a small population that's showing a decreasing trend may suggest just the opposite, that things are improving. So I think it's really a matter of considering both. And I also think in all of our counties, off-campus locations, and obviously for our campus location as well, we have to make these decisions in concert and cooperation with local government officials, our county mayors, county governments. We can't, I don't think, decide things in isolation, because honestly, what we do has an impact on the community and vice versa. So we've got to work together on that. I know Dr. Burns and the Extension Regional Directors are thinking that through just a little further now that we're into phase one. What do we do to consider further changes and whether we can move ahead with a phase two approach or not? But again, I think even as we consider that, we need to think about what local officials are thinking in that regard as well, and work together, just as the legislation states. Our extension advisory councils are to work together with county government. So that's not a hard and fast answer. It's impossible, I think, to give one measure and say this is it. This is what we're going to base our decisions off of. But I think, again, paying particular attention to trends is certainly wise counsel that Commissioner shared with us today.
Great. Well, changing gears slightly, this question asks, with the announcement of the largest university in California not planning on bringing students back to campus in the fall, what impact will that have on our plans to be back on campus this fall?
Honestly, I think no direct impact at all. Every campus is in a little different situation. And every campus, again, just we just talked about, is in a community with a little bit different situation. So I don't think that one university declaring, we're going to shift all of our enrollment online necessarily has any direct impact on us. I think, nor would it have a direct impact necessarily on any other institution across the U.S. I happen to know that the University of California system is still intent on reopening, and that's a huge system with hundreds of thousands of students. So even in the state of California, there doesn't seem to be at least an immediate impact from that announcement. I think what's important is for each of our universities and each of our offices, again, to think about what conditions are like, what the experience has been as we have moved into a reentry phase, and then make hopefully informed and knowledgeable decisions about moving forward. Testing, as Commissioner Piercy mentioned, is critical, but testing also still just gives you a point in time. So I know there's a lot of talk across all university campuses, especially about testing, because if you think about the really confined populations of students in dorms, it's really critical. And as she mentioned, the rate of transmission is very high in those situations. So testing is going to be critical, but there's a lot of developments going on with regard to testing as well. She made just a brief comment about antibodies, and that's testing to determine if a person has had COVID-19 and therefore potentially may have some immunity. All kinds of challenges with regard to that. First of all, we don't know, even if we are certain you've had it, we don't know if that necessarily gives you immunity. There's no real definitive research on that yet. Secondly, the tests for those antibodies are not very specific. So it may be that you've had one other coronavirus, maybe not COVID-19, but some other variant. And we don't know if that gives you protection in any way from COVID-19. So all of this is still a work in progress, obviously, but it's very important for our workforce, for our universities, for corporate America as well. Everybody is looking for a vaccine or a test or some way to determine immunity, and we're not there yet.
So Tim, we've had a number of questions, and I've had these even offline. Clarification on travel. What travel is banned? What travel is accepted? If somebody takes a vacation, as I know we're getting into the summer months, if somebody takes a vacation that takes them out of state, what are the quarantine guidelines? And if they have to physically be in their office, do they have to quarantine for 14 days? So anyway, if you could just address travel overall, that would be helpful.
Good. And you know, this is a logical topic of discussion, because as we think about reentry and phasing up our work, much of what we do, or much of what we used to do at least, involves travel. And last week I made it a point to remind everyone to take annual leave. So I'm to blame for creating some of these questions, right? Because if you're going to take leave, why not go to a nice sunny beach somewhere? And then if you do that, well, what does that say about your return to the workforce? So first of all, let me start with what we've written down, and that's in our guidelines, and that is that if you go out of state privately, you know, as a part of annual leave, when you return, we would like you to self-quarantine for 14 days, but that should be in conversation and in under the planning with your supervisor. So I think unfortunately, it depends. If you went to a remote forest in West Virginia and never saw another human being for a week of annual vacation in a cabin, then what you need to do and what makes sense for you and your coworkers may be very, very different than if you were on a beach in some southern state and in very close proximity to hundreds of other people for days at a time. You know, that when you return, we may want to have a little more strict restrictions on your engagement with the workforce. So I think, think about that, talk with your supervisor, determine what makes sense. We've encouraged everyone to work remotely that can for the continuing. And so it may not be in the near term much of a challenge to say, well, I'll just continue to work from home for 2 weeks after I get back. As we look further out, and I know I'm thinking about that as well. Well, we get to July, and that's a normal time to get away for a week. What's it going to be like in July or August? And when we return, what will we need to do? For right now, our crystal ball is not great, so we're just going to say, think about having 14 days of self-quarantine when you return. But if conditions get better between now and then, we may be in a position to relax that guidance and enable you to come back to the workplace. I think, for myself, I'd want to think about what is my return from a out-of-state location due to the risk of those I work with. And so it's thinking about others as opposed to thinking about yourself, because if you've been there and been exposed to someone, that's already happened. The question is, how does that impact potentially others in your office? So I think if we all think about it from that standpoint and then talk with our supervisor and work out a plan, we can take a vacation, we can go enjoy some time away from the office or away from home, but we can also return safely and do so without furthering the spread or the risk associated with the virus.
Great. And a reminder to everyone, these guidelines are available on the coronavirus website. So do take a minute and look at those if you have further questions. We have, looks like one more question. And the question is, if your local physician group offers the antibody testing and you test positive for coronavirus, does this information need to be relayed to the university?
No, at this point, we're not requiring that, and that would be personal health information as far as I'm concerned. The only thing required to be reported is a positive COVID-19 test result. But the antibody test, we really don't have any requirement for that to be shared, nor am I certain what we would do with it at this point. So I think, it sounds like it could be good news for someone, or it could be bad news, because the other thing we don't know for sure is if you have a positive for that antibody test, that doesn't necessarily mean that it was weeks ago. It could be that it was just last week or currently even, or it could be from 6 weeks ago. So the science there is still not well defined. We don't have enough research, in my opinion, and the opinion of our medical experts, to really act upon that information yet at this point. So I think, again, it may be helpful to an individual, but organizationally, we're not requiring that information.
Okay, one more did come in, and that is, what about going to board meetings or other groups of which you're a member or advisor? And maybe it's more than 10 people. As long as you social distance, is that okay to attend these?
Well, we're really still trying to stress, limiting exposure to 10 people or less. But obviously, as you think about having classes resume in fall, we can't restrict our classroom size to 10 people. What we can do is establish social distancing, 6-foot spacing for our students and so forth. So I think my judgment there is that if it's an external group creating a meeting or hosting a meeting or some kind of an event, and certainly if it's less than a huge crowd, but maybe slightly more than our guidance of 10 individuals, provided there is good social distancing, provided there's an opportunity to wear masks and observe good sanitation. I don't think at this point that we should absolutely decline each and every one of those. I think, again, it would be a matter of asking a few questions, like what steps have been taken in preparing to do this safely. And if you're comfortable that there have been appropriate steps taken to acknowledge that everyone's not going to be sitting shoulder to shoulder, and that there won't be a really conducive environment to spreading disease, then I think that would be something that we could and should participate in.
Great. Well, a lot of great information today. So Tim, do you have any final thoughts you wanted to share with everyone?
Yeah, thanks, Lisa, and thanks once again for everyone joining us today. I know that seems like sometimes we live, eat, and breathe coronavirus, and I worry that once a week is getting to be too much in terms of sharing information. But I really appreciate a chance to interact, to know what folks are thinking about, what concerns are out there, what questions are out there. So I hope it's helpful for you as well. And of course, I love seeing faces since we don't get to see each other well enough or often enough anymore. So thanks, first of all, for joining us today. Second of all, let me harp a little bit more on where I started, and that is, if you're back to work in terms of the office environment or laboratory or classroom, when you're present, you're to be wearing a mask, and you're to be taking care with sanitation. You're to be filling out that checklist every morning to remind yourself and remind others that you're healthy, that you're in a position to safely be at the workplace. So wear a mask, and remember that wearing that mask, again, isn't for you. It's largely out of respect for others. It reduces the transmission of particles that could infect others. So on the chance that one of us is actually positive but asymptomatic, wearing that mask makes sure we don't contribute to the spread of coronavirus. So if you think, gosh, I'm strong, I'm tough, I'm in great shape, I don't need to wear a mask, all those things may be true, but the mask isn't for you, it's for others. So put it on and help your coworkers, help those that you work with, help your students to remain safe as well. We certainly will continue monitoring trends, rates, cases, all the data that we've talked about just a little bit this morning as we think about phase 2, but we're not at a point to say, here we are, phase 2, back to work even further. So keep doing what you're doing. I think we're making great progress. I think you all are doing all the right things. And if these trends continue, and if the numbers continue to show decreases, we'll let you know more about phase 2. Many of the plans are already posted for phase 2. but let's not charge ahead just yet. Let's be sure we're at the right place at the right time, at the county level and at the campus level. So we'll worry more about phase 2 again when we get a little bit closer to the right time. So other than that, I'd just say carry on, do what you're doing. Thank you for serving, whether it's students or stakeholders or conducting research, serving our animal clients. We appreciate your continued hard work and productive approach to things. Hang in there. We'll get through this. I feel better every day, honestly, and I hope you do too. This is, an unprecedented challenge, but we're going to learn some new things. We already have discovered, I think, some great approaches to things that we probably wouldn't have discovered otherwise. So we'll make the best of this. And we'll continue to move ahead. So I'd wrap it up with that, Lisa. And thanks to Lisa for hosting these once again. I need to give a little shout out to Mike Stanley, who always makes our technology work. And he's behind the scenes, but he's back there making sure things work well. So thank you, Mike Stanley. And Lisa, thanks for doing a great job moderating once again, too.
Well, thanks, Tim. We appreciate it. And thanks, everyone, for being here today. Have a great weekend.